Okay, thanks everyone for joining. As a reminder, please make sure to sign in using the QR code on the slide or the link in the chat. And now I'll turn it over to Adam.
Thanks, Jessica. Can you all hear me okay?
Yes.
Okay. Yeah, good afternoon. My name is Adam Stevens. I'm a member of the Cancer Education Work Group. Thank you all for joining the presentation today. Really excited to get going here. As Jessica said, there is a sign-in link in the chat. You can either scan the QR code or click the link. Doing so is really important so we can get attendance, but also identify interesting topics for future discussions and presentations such as today. Let me just pull up the rest of my notes here. And also, you'll notice that as you join the meeting, you will be muted. We ask that you contain your excitement and questions for the end. There will be a Q&A session following the presentation. And then you can also use the chat feature to pose any questions during the talk. And if not addressed during the talk itself, there will be an opportunity to address those during the Q&A. So without further delay, I have the privilege today of introducing today's speaker, Dr. Teresa Medina. Dr. Medina is an assistant professor of medicine in the Division of Medical Oncology at the University of Colorado. Her primary clinical interest is the treatment of cutaneous malignancies, so including malignant melanoma, particularly mucosal melanoma, as well as Merkel cell and advanced keratinocyte carcinomas such as cutaneous, squamous, and basal cell carcinomas. Research-wise, her interests focus on the use of novel agents for the treatment of metastatic melanoma and other cutaneous malignancies. As far as professional associations, she's a member of several professional societies, including the American Society for Clinical Oncology, the Society for Melanoma Research, and the Society for Immunotherapy of Cancer. She currently serves on the NCCN Committee for Non-melanoma skin cancers and offers guidelines for the management of immune therapy-related toxicities, which will be one of the topics of today's talks. And then just on a personal note, there has been some overlap with some of our clinical trial patients between melanoma and phase 1. And there hasn't been too many encounters that we've had to work with patients together, but every encounter that Dr. Medina and I have had has been just filled with positivity and enthusiasm. So I'm just really excited to have the opportunity to introduce her today, and looking forward to learning more about today's topics. So without further delay, I bring you Dr. Teresa Medina.
Thank you so much. That was so nice. So I'm excited to kind of go over these topics as well today. And I apologize, I had some issues with my slides last night, so they're a little jumbled, but hopefully we'll get through it. I'm just trying to share my screen here. Can everybody see that okay?
Yes.
Okay. So basically, I just want to give a brief overview of melanoma and spend most of the time talking about the immunotherapy toxicities. So just as an introduction, melanoma is not just a skin cancer. Melanoma that starts in the skin is the most common way that it presents, but it's very interesting. I find it a very interesting cancer in that the cell that it starts from, the melanocyte, can turn into melanoma at other anatomical locations in the body, like in the eyes and in the mucosal surfaces of the body. And melanoma arising in all of these different places can actually behave very uniquely, and the genetic composition of these cancer cells are unique as well. So, so despite kind of being all-encompassing, an all-encompassing cancer under one name, they're all very different. So I just put up some pictures here to scare you. These are all melanomas on the skin, so everybody go see dermatology and wear sunscreen. So the greatest thing about melanoma has been the advancements that have happened over the last 10 years. The incidence of melanoma has been increasing over the last 30 years, but fortunately most of the diagnoses are in early stages, and so over 90% of patients can be treated and cured with surgery alone. So we're primarily focused on the patients that have advanced and metastatic disease, And one of the best things that's happened over the last few years is that the survival rate for patients with metastatic melanoma has significantly improved. In the very bottom right corner, I put in a Kaplan-Meier curve that shows the survival for patients who were diagnosed with metastatic melanoma prior to 2011. And all of these patients had brain metastases, which is unfortunately very common for patients with metastatic melanoma, and their prognosis has historically been very poor. So you can see here that over about 50% of patients died within about 6 months of being diagnosed with metastatic melanoma in the past. And then in the upper right Kaplan-Meier curve, this shows the kind of sentinel trial that looked at the combination of two of our immunotherapy medications that we use frequently, ipilimumab and nivolumab. And this was the 4-year survival update, which has been recently reported, the 6.5-year survival update. But here on this graph at 4 years, the overall survival is about 60%. So a significant improvement for our patients, which has been very exciting. And then in 2018, that was the first time that the SEER database showed that there was a decrease in the expected deaths reported from melanoma. So these are just a list of the currently FDA-approved treatment options for melanoma. So we kind of think about the treatments for advanced and metastatic melanoma as branching into two options. We have what we call our targeted therapies, which use the small molecule kinase inhibitors that inhibit the mutation in BRAF, which is a gene in the MAP kinase pathway that's frequently mutated in majority of cutaneous melanomas. About 40% will have a mutation in this BRAF gene. And so we have 3 approved targeted therapy combinations that I listed here. There hasn't been any head-to-head trials comparing these different combinations. So we basically kind of base on which combination we'll use on side effects or kind of individualized to the patient. Our mainstay of treatment for metastatic melanoma is to use immunotherapy, and this really does not depend on any molecular driver. And so there are 3 what we call checkpoint inhibitors, which we'll talk about later, that are approved for melanoma, and 1 combination of 2 checkpoint inhibitors that we use often, ipilimumab and nivolumab, and then 2 PD-1 antibodies, nivolumab and pembrolizumab. And these are approved for other cancers as well, so you've probably been heard them for other cancer or tumor types. In addition to those, we have an oncolytic virus that we can inject into melanoma tumors. This is a modified herpes virus. It's the HSV-1 virus that causes most cold sores. And so this is a virus that has been genetically modified so that it's no longer pathogenic in terms of infectious pathogenesis, but it will stimulate production of an inflammatory cytokine that we call GCSF. And so that's also approved for metastatic melanoma. And then finally this year we had a study that looked at the combination of our kind of 2 mainstays of treatment, the targeted therapy realm plus immunotherapy. And so that's a combination of one of the BRAF-MEK drug combinations plus atezolizumab. So in cancer trials, often what we're looking at is curves that look like this. This is what we call a Kaplan-Meier curve, and this tells us about survival. And so the higher that the curve is on the y-axis, the better the survival of the patient. So that's what you're kind of shooting for. And then the more that we can push the curve out towards out on the x-axis, then that will kind of give you a sense of what the response rate might be. And so I just brought this up because I think it's interesting to look at, when we look at our small molecule kinase inhibitors, we expect that the response rates for those will be pretty high. And so we can see a dramatic change between not treated patients and patients that receive these small molecule inhibitors where they'll have a benefit of tumor shrinkage that'll happen more rapidly. The downside of the small molecule inhibitors, at least in melanoma, is that they tend not to be very durable. So you can see that the red line here joins up with the light blue solid line eventually, and so most patients still end up dying from their cancer, unfortunately. What the transformation has been with the use of immunotherapy is that we start to see this, what we call tail of the curve, where on the dotted lines or dashed lines, you can see how they kind of come down over time, but they start to flatten out, and then they kind of stay the same at some point. And so that's what we call the tail of the curve. That's what we like to see with any of our therapies, but that's what we think leads to that potential that we might have curative options for our patients if we can get the immune system to fight off these cancer cells. This is just a cartoon that kind of displays what we're looking for in terms of our targeted therapy. So in melanoma, often what is constitutively activated is this cell signaling pathway that we call MAP kinase, and the canonical mutation that we'll often find is in this gene BRAF. There's a particular codon mutation that will often be found when we're looking at these gene mutations, and we call that V600. And so that's the mutation that we're looking for. If patients have a mutation in BRAF V600, then we know that the inhibitors that we have can block the growth signal. And what's been found over time is that if we use 2 inhibitors of the MAP kinase pathway, the BRAF protein and the MEK protein, that together they work better, they work longer, and paradoxically they actually are better tolerated. So normally when you add a bunch of drugs, it causes more side effects, but in this instance it actually is a little bit easier to take. This is kind of now switching more towards kind of the immune therapy realm, which we'll spend the rest of the talk on. And so in immune therapy, this really depends on the interaction of one of our immune system that we call T cells and its interaction with cancer cells. And so you have hundreds of millions of different types of T cells. Each one of those T cells has a very unique T cell receptor that can recognize a particular antigen. And so basically these T cells are constantly looking for foreign invaders. Primarily, we think about this in terms of infectious diseases, and so different bacteria or viruses. But it turns out with all of the mutations that happen within a cancer cell, there's several different mutations that will develop these new antigens that then might be something that a T cell could recognize. And so the T cell is, in a way, also a specialized cancer cell fighter as well. However, you can't just have T cell recognition from the T cell receptor. It turns out that there's a lot of other either stimulatory or inhibitory signals that are at play in ultimately activating the T cell, which we'll talk about again later. So this is just a kind of brief cartoon about the different immune therapy medications that are approved for multiple different tumor types now. On the right-hand side, this is basically showing how the anti-PD-1 and anti-PD-L1 antibodies work. So basically, within a tumor microenvironment, you have your cancer cells, and then within the tumor, there are also lymphocytes that are within the tumor as well. And so you'll have these T cells that hopefully can recognize something that's different about that cancer cell. So you have the T cell receptor binding to the antigen on the cancer cell. And then there are what we call inhibitory signals that if those are activated, so meaning like you're stepping on the brake, then the T cell's not going to turn on. It's not going to fight off that cell. It's just going to kind of let that cell do whatever it wants. So obviously that's what the tumor wants. And so the way that the anti-PD-1 and PD-L1 antibodies work is they're basically preventing that interaction from happening. So if you don't have a brake anymore, then you could potentially start moving again when you put the gas down. On the left-hand side, that's a cartoon of what the anti-CTLA-4 antibody, the way that works. Anti-CTLA-4 is ipilimumab, and that's the only CTLA-4 antibody that's approved, although it is approved for multiple different tumor types. And so what is happening with the anti-CTLA-4 antibodies is you have these cells that we call dendritic cells, and they're basically scouring for, again, foreign invaders, and they're trying to help show where T cells kind of to help the T cells know where the action is. So they'll pick up different debris, different kind of pieces of cells, and then they'll show them to the T cells to hopefully stimulate them and to say, like, hey, you need to go out to the lungs. There's a virus there that you need to attack, or things like that. So the anti-CTLA-4, or I should say the CTLA-4 receptor, is another one of those inhibitory receptors where if it's activated, it's turning the brake on of the immune system. And so even if the dendritic cell's trying to show the T cell a bad guy, the CTLA-4 will prevent that T cell from being activated. So the ipilimumab is an antibody that, again, kind of prevents that interaction and then hopefully then promotes stimulation of the T cell. So you have a lot of different types of T cells. Basically, you start off with these T cells that we call naive T cells, and then those can get primed when they recognize a certain antigen. And then from there, there's several different pathways that T cell then can mature into. So you can have T cells that become what we call fighter T cells or cytotoxic T cells, and those are the T cells that we want to get activated to fight off our cancer cells. You also have T cells that can turn into kind of more tolerant T cells, and so those are important to try to minimize an immune reaction. And you might think, well, when would you not want your T cell to be activated? Well, you don't want your immune system to be attacking your own body all the time. And so that tolerance that can happen is really to try to protect us from our own immune system. And that's something that the cancer cells can then take advantage of. Sorry, did these kind of out of order? So this is just a cartoon to kind of show you how that TVEC works, which is the oncolytic virus that I had mentioned earlier. So this we inject directly into tumors, whether it's a tumor on the skin or a lymph node, and it basically leads to cell death by the virus replicating within the cancer cell. And then as that cancer cell dies, it will release the cytokine GCSF to help stimulate inflammation and hopefully help recruit more immune cells to the tumor to then help kind of fight off the existing cancer cells. Interestingly, this does not seem to be transmissible. So when we're injecting this into tumors, the patients don't seem to be able to transmit that to their family members, which is obviously a good thing. So this is a really interesting graph or figure here, basically showing what's happened for melanoma over the last 50 years. So on the top figure, what that's showing is the time that the drugs that were approved for advanced and metastatic melanoma, when that happened. And so you can see there's a lot of open space from 1970 to 2010. They had very few drugs that were approved at that time, but only 3 drugs approved, and they really didn't work that well. And so that was kind of the bad old days of melanoma, where we had no really effective treatment for patients with metastatic melanoma. What's been amazing is in the last 11 years, there's just been rapid approvals of all of these different drugs that I've been talking about. So the checkpoint inhibitors, the targeted therapies, and the TVEC, and then using those in different combinations to try to improve the response rate and overall survival. The bottom portion of the figure here is looking at the different studies that have been done that have led to the approval of these different therapy options. And basically what this is showing is that if you look at the 2-year overall survival, which was reported for all of these studies, what is the expectation for these patients? And you can see on the far left-hand side, when we were just stuck with a chemotherapy called dacarbazine, or a cytokine that we used to use called interleukin-2, the 2-year overall survival was less than 20%. So the prognosis was very poor for patients at that time. Now, when you look over to the far right, with the use of immunotherapies and targeted therapies, the 2-year overall survival is now around 50 to 60% in some studies. So, This is just a combined chart showing the results of the targeted therapies and the responses that we saw for patients with metastatic melanoma. Again, these have not been compared head-to-head, so this is showing the study that looked at the approval of the combination of vemurafenib and cobimetinib, and that was the COBRIM study. COMBI-D is another BRAF-MEK combination, dabrafenib and trametinib. Columbus is the combination of encorafenib and binimetinib, and then the far right trial, the IMspire 150, this is looking at the combination of vemurafenib and cobimetinib with one of the PD-L1 inhibitors, atezolizumab. And basically, the objective response rate is very similar across all of these trials, and when we look at the progression-free survival, it's also very similar. Again, these haven't been compared head-to-head, but overall, the efficacy is very similar. What is very interesting is when you look at the trial that used the combination of the targeted therapy plus the atezolizumab, the 2-year overall survival had not yet been reached, which was better than what had been reported for the combination BRAF and MEK inhibitors alone without immunotherapy. This is the Sentinel trial that led to the approval of ipilimumab and nivolumab. This study was looking at the combination of ipilimumab and nivolumab as compared to ipilimumab alone, or nivolumab alone compared to ipilimumab alone. So this was not powered to show a difference between nivolumab alone versus combination nivolumab and ipilimumab, so that's something to kind of keep in mind here. And then again, this is a 6.5-year update. And what we see is that at 6 years, 50% of patients in the combination arm, again, still alive, which is dramatically better compared to where we were just 10 years ago. Skip that. All right, so we were kind of talking about the immune system already. This is just a Venn diagram showing kind of the different components of the immune system. In the purple square, that is demonstrating what we call the innate immune system. And so that immune system is basically kind of primed to recognize certain patterns. So they'll recognize double-stranded DNA, for example, or double-stranded RNA, I should say, for example, where our eukaryote cells or human cells will not have double-stranded RNA, so that is definitely an indicator that that's a virus or some kind of foreign organism. So they're just kind of recognizing patterns, but they're not looking for anything specific. The right-hand side is showing the adaptive immune system, which really is looking at our lymphocytes, our B cells and T cells. And these are the specialized portions of the immune system. So each one of these cells has a specific target that they're looking for, and they're only going to recognize that one target, which I showed you before. So we basically call these humoral and cell-mediated immunity. So humoral immunity means that the B cells are making antibodies and they release antibodies. So it's not necessarily the cell itself that's leading to cell death of other organisms or cancer cells. And then the cell-mediated immunity is basically looking at T cells, where those are the T cell itself is actually causing other cells to die if they think that they're bad or foreign. So I've kind of talked a lot about how these specialized T cells are very important in cancer cell recognition and killing off of cancer cells, but there's so many other steps that need to happen in terms of the relationship between the immune system and the cancer cells. So you have to have a way for immune cells to get into the tumor microenvironment. You have to have T cells or immune cells that recognize the cancer cells. The T cells have to be functional. They have to be able to kill off the cancer cells. And then once the cancer cells die off, they might release more antigens that then hopefully will help stimulate or recruit more immune cells to the tumor and be able to kind of fight off those cancer cells again. And then the T cells or immune cells basically have to be traffic from wherever they are. If they're, in the spleen, they have to get to the lung or wherever those tumors are. So they have to go through blood vessels and lymph nodes and be able to infiltrate the tumor again. So it's not just one thing. It's an orchestra of all these different events, and you can see that there's a lot of different ways where the cancer cell can basically outsmart the immune system and be able to kind of be resistant to immune therapy. So this is that picture I showed you before, again, just as a reminder that the T cell activation requires multiple steps, not just recognition of the foreign cell or the foreign invader. So we think of these kind of regulatory signals that exist on T cells as having two different functions. You can have stimulatory regulatory receptors. So if those are activated, then it should stimulate the T cell to become a cytotoxic T cell or killer T cell. You also have these inhibitory receptors, and those are the ones that we know more about in terms of the PD-1 inhibitors and CTLA-4 inhibitors. So if the inhibitory receptors are activated, that will shut down or deactivate T cells. So that's what we're trying to prevent within the tumor microenvironment. And so you can see there's a lot of these antibodies that are being developed and used and in clinical trials, and you probably see a lot of these antibodies. And we're just trying to figure out, is it, how do we best stimulate these T cells? Is it a combination of multiple inhibitory antibodies? Is it a combination of stimulatory and inhibitory antibodies? And so there's a lot still that we don't quite understand about how to activate these T cells in the way that we want. So as I mentioned, CTLA-4 and PD-1 they work differently. When we use them together, they can be synergistic in that they have different mechanisms or modalities of activating T cells. And these are the approved checkpoint inhibitors that are out for multiple different tumor types. So the only anti-CTLA-4, as I mentioned, is ipilimumab. For the PD-1 inhibitors, we have nivolumab, pembrolizumab, and cemiplimab. And for PD-L1 inhibitors, we have avelumab, durvalumab, and atezolizumab. So the rest of the talk will kind of talk about the downside of checkpoint inhibitors, which is the side effects. And so ITIS stands for inflammation. So basically what we're thinking about is the itises of checkpoint inhibitors. And so this is basically a result of T cell function. Again, normally your T cells are in a tolerant state so that they're not attacking your own body. When we give these checkpoint inhibitors, we're removing that brake and then potentially causing increased activation of these T cells non-specifically. So they're just out there, attacking anything that they see, essentially. So these are relatively frequent. They vary in terms of the severity, but it can be very impactful on patients' mortality and morbidity. Unfortunately, at this point, we don't really have ways to identify patients that are at risk for certain toxicities. So we just basically have to educate patients and their support caregivers in terms of the possible side effects that might happen, the frequency that we usually see these side effects, and how we might manage them. And so oftentimes patients will come in to see me in clinic and they'll say, I saw that drug on TV and I saw the long list or heard the long list of side effects and there's no way I'm taking that drug. So it's really, making sure that patients understand that these can happen. But that the incidence is safe enough where it's still reasonable to use these drugs in their care. So how do these side effects happen? Well, there's multiple different ways that the immune system might start attacking your own body. One might be that the cancer cells and your normal cells might sort of look similar. So as an example, in melanoma, what we'll see is that the melanocytes, which are the original cells, the progenitor cells for melanoma, they look similar enough to the melanoma that the immune system is fighting, that the immune system will start attacking normal melanocytes. And that leads to this condition that we call vitiligo, where people will lose their pigmentation or lose the melanin production, where they lose melanocytes in the skin. So that'll lead to these kind of white patches on their skin, or they can have lightening of their hair as they lose melanin production in their hair follicles. And so it's basically because those cells look similar enough that the immune system is not really discriminating between the two. Another possibility is that as the immune system is killing off all those cancer cells. It is so successful that it releases so many cytokines, which are these proteins that the immune system uses to talk to each other, that the cytokines then kind of induce this inflammatory reaction, and that can be even this systemic inflammatory reaction where it mimics a very severe illness like we see in cytokine release syndrome. Another possibility is that you can have CTLA-4 receptors expressed on other cells besides immune cells. So an example of this is the pituitary that expresses CTLA-4. And so as the ipilimumab binds to the CTLA-4 receptors on the pituitary glands, it also can induce inflammation and sort of this autoimmune reaction against the pituitary gland. And then another thing that can happen is you can increase the number of antibodies that get made and released by other lymphocytes, like the B cells, which then will also cause this autoimmune-like reaction. So there's lots of different ways that these checkpoint inhibitors might induce an autoimmune syndrome or condition. This is basically kind of showing the same thing. The other thing we think about, not just in terms of the immune cell function itself, but the surrounding environment. So there might be underlying genetics that might predispose people to developing certain side effects. We haven't been able to really identify that as yet to sort of be able to counsel patients or avoid certain agents for patients, but it's definitely something that we're looking into. And then the environment, other medications, other medical issues, all of these things might combine in a way to increase the risk for the development of these immune-related side effects. And in terms of what can happen, where is the immune system likely to attack? Basically, everything's fair game. What I tell patients is that anything head to toe can be a target for the immune system. And so I tell them basically, once we start this treatment, anything that happens, we're blaming on the immune therapy until proven otherwise. And we need to know about every single new symptom that they have, because that can help us figure out what toxicity might be happening. And so this is just kind of showing you that of all the organ systems, you can have different autoimmune reactions in all of these different places. The likelihood of these different side effects vary depending on the organ system, and the severity can vary as well, but really anything is fair game. Apart from these autoimmune reactions, other side effects that we can see that are pretty common that are not necessarily related to the immune attack, but maybe a result of kind of systemic immune activation or inflammation would be feeling fatigued. Like if you catch a cold, you have a couple of days where you're feeling more fatigued. It's not necessarily from a direct injury, it's just kind of a response of your immune system. The cytokines that get released can cause you to have a fever. So again, it's not necessarily a direct immune damage or inflammation, but just a reaction to the inflammation that's happening. You can also get infusion reactions as you're getting these antibodies, and so that's not necessarily an autoimmune reaction like we're thinking about for these other organs. But those are other events that we need to make sure that patients are aware of before we start treatment. So basically, the autoimmune effects that we're thinking about when we're using these drugs is resulting from the T cell activation, and that leading to essentially destruction of whatever that T cell is targeting. The other thing that's expanding when we look at other tumor types, not necessarily in melanoma, but for lung cancer, for example, we're using these checkpoint inhibitors with chemotherapy. I talked about how we're using the checkpoint inhibitors with targeted therapy, and that's happening with other cancers as well, and other tyrosine kinase inhibitors. We can use checkpoint inhibitors with radiation, and with all of these different strategies, we're still trying to sort out, how does that change the incidence of these immune therapy toxicities? Are you more or less likely to get certain toxicities? Does the timing vary? Does the severity vary? So there's a lot of ways that adding all of these drugs together can make the delineation of side effects much more complicated. there are some resources that we can look to in terms of what to look for when we're using checkpoint inhibitors, what side effects might be developing and how do we manage them, and what do we need to do if they develop in terms of workup. And so these are just a list of the different places that you can go to see. When we're talking about the autoimmune reactions from checkpoint inhibitors, we'll often use the abbreviation IRAEs. And so I'll kind of use that through the rest of the talk here. Basically, once we see the development of an IRAE, we're pretty, you need to assess the severity of the symptoms or the inflammation to determine whether you need to use corticosteroid as an immunosuppressive or other agents, or is it something that you can watch for a while. We know that the earlier we recognize that these events are happening and the earlier we start treatment, not only will patients feel better faster, but it will make the resolution of the side effect much easier. Patients can taper off the steroids more, sometimes more quickly, but definitely easier, and then they're less likely to have rebound effects over time. Often managing these side effects requires multidisciplinary teams, so it's not just the oncologist, but it's the nurses and the pharmacists and other specialists like cardiologists or pulmonologists, depending on the type of side effect that develops. And at this point, it is thought, but not proven, that depending on the tumor type that you're treating, you might see side effects that go along with that tumor type. I mentioned vitiligo for melanoma. It's also been shown that patients with lung cancer who are getting immunotherapies might be more likely to get lung inflammation or pneumonitis. And so we are looking for that in other cancers as well, that kind of association between those shared progenitor cells and the cancer cells. I kind of talked about this already. So basically, when we're looking at these immune-related toxicities, they're very common as a whole. There's just certain side effects that we're more likely to see. But if you look across all of the studies, about 80% of patients will report some kind of IRAE during their course of treatment. However, the majority of them don't necessarily require steroid intervention when we're looking at the studies with PD-1 antibodies alone. Most of the IRAEs are reversible, so they're not permanent or chronic conditions, although about 10 to 25% of patients may have these kind of prolonged or protracted courses of the side effects or potentially permanent side effects. So that's why early recognition and treatment is key. And when we're looking at the difference between the PD-1 or PD-L1 inhibitors used by themselves versus the combination with the CTLA-4 inhibitor, we know that the severity of the side effects is much higher, and so the need for steroids is a lot higher. This is basically just showing you the difference between the CTLA-4 and PD-1 inhibitors. You can see that you're more likely to get grade 1 and 2 IRAEs across the board with all of these agents, but with the PD-1 and PD-L1, most of the toxicities are grade 1 and 2. But when you look at the severe IRAEs, that tends to be more often in the patients that receive CTLA-4 antibodies as compared to PD-1 and PD-L1 inhibitors. In terms of timing on onset, so the top graph I like just kind of shows the difference between CTLA-4 and PD-1. So when we're using ipilimumab by itself, we know that there's a much higher chance of developing some of these toxicities. They tend to happen earlier, and they can be they can last longer. So typically, the skin toxicities or rash happens early on within the first couple of weeks of starting treatment, but then tends to fade off after about 10 weeks. The next one that we'll often see is diarrhea or colitis. That usually happens between the second and third cycles of ipilimumab, and then again seems to taper off after about 10 weeks. And then the endocrine toxicities and the pneumonitis can be later, where they develop kind of after 8 to 10 weeks. When you look at the PD-1 inhibitor graph over to the right, so that shows you that the area under the curve is the frequency of the side effect that we'll see. So the skin, you can see, is the most common one that will occur. Again, that happens kind of early on. It's one of the first side effects we'll see, and then tends to drop off after about 6 months, where patients won't really develop any new rashes after that. That's again followed by GI side effects like colitis and diarrhea, and then followed by hepatitis. And then again, those endocrine and pulmonary side effects tend to be a little bit later. And then at the very bottom, kind of the bar graph there, it's basically, again, trying to show you the time where you might see these side effects develop, again, and for patients that are receiving PD-1 inhibitors. So it can happen at any time, but there's certain points where you're more likely to see side effects over another. This is just looking at the difference between the combination of ipi-nivo versus nivo. So the orange graph or lines here are basically showing that the side effects that we see with the combination therapy happen sooner and they last longer compared to the side effects that we see with nivolumab alone, or ipi alone in this case. This is the general guideline in terms of what we think about when we're treating side effects. So we grade 1 to 5, but really we're only managing 1 to 4. And so basically for patients that have grade 1 symptoms, most of the time it's not something you necessarily need to use corticosteroids to treat. You can just treat symptomatically, but you need to monitor more closely. Once you get up to grade 2, then you can watch closely. You might need to start steroids, especially if there are symptoms that have been more chronic, if they've been going on for several weeks. You can still continue the checkpoint inhibitors, but if they continue to have symptoms, then you might need to discontinue therapy if they're not improving. For grade 3 and 4 side effects, so you're basically starting high-dose corticosteroids for those side effects. You at least are holding checkpoint inhibitors when you start steroids, but you're more likely to discontinue with these grade 3, 4 toxicities. And then if they have persistent or recurring symptoms, then you'll also think about using what we call steroid-sparing agents, which are other immune suppressive drugs that we might add to, again, further suppress that immune response or immune stimulation. And the typical dose of steroids that we start off with is usually prednisone, and we use it on a weight-based dosing of 1 to 2 milligrams per kilogram per day. And the dose really depends on the severity and the type of side effect that we see. We know that patients who have an underlying autoimmune disease, they're more likely to develop these IRAEs when they're exposed to checkpoint inhibitors. That makes sense. Their immune system already is dysfunctional and sort of hyper-stimulated, so giving them these immune stimulator antibodies, the checkpoint inhibitors, they're going to be more likely to have side effects related to their underlying autoimmune disease, and then also increased risk for side effects that are not related to their underlying autoimmune disease. And then patients that have had checkpoint inhibitor in the past but stopped for side effects, when you re-challenge them, they're also more likely to have side effects. Again, they could be the same as what they had initially, or they could be new ones. So fatigue is the most common side effect that people report. Of all of these side effects, about 80% of patients will report fatigue in the clinical trials where they looked at these immune checkpoint inhibitors. This is also the hardest to treat. When patients have fatigue, there's a long list that you have to think about in terms of what could be causing the fatigue. Are they having other side effects? Are they starting to have changes in their hormone system? Is it just related to their cancer and maybe their cancer is getting worse? So there's a lot of things that might be contributing. Basically, the way I approach fatigue is just trying to support their behaviors, making sure they have good sleep schedules. Exercise can help with chronic fatigue, but apart from that, there's really not any pharmacologic treatment that we can give to help with their fatigue. So skin toxicities, those are the next most common side effects that we'll see, and this can present in a variety of different ways. The most common side effect we'll see is what we call a maculopapular rash, and that's the figure that's on the far right on the slide. So it's just kind of this kind of redness over the skin. It can be just a very small patch. It can be kind of distributed throughout the trunk and the extremities. Typically, this is mild enough that we can just manage with lotions and topical steroids and antihistamines, but it's something that, depending on the severity of itching, is oftentimes the issue. Then we might have to use oral steroids. Vitiligo, I talked about, that's the photos that are in the middle of the slide here, so you can see the kind of white patches on the arm and then the white eyelashes. And usually this is irreversible. We don't typically treat this when it develops. We just make sure that patients are wearing sunscreen since they don't have any melanin protection anymore. And then on the bottom right is a photo of a psoriasis-like lesion. Again, this is just another type of rash that we might see. We might need to treat this more aggressively with topical steroids or oral steroids. And then lastly, the photo with the mouth, that's showing what we call a lichenoid reaction, which again is just an inflammatory reaction in the mouth. The severe skin toxicities that are more concerning is when we see these kind of full body immune reactions, and this is basically the immune system attacking the skin and the dermal layer of the skin. So it can basically lead to full thickness skin sloughing, which is almost like having a third-degree burn everywhere. So the two most common that we think about are syndromes that we call Stephen-Johnson syndrome and TEN. And this is basically a full-body rash, and it can involve the mucosal membranes or not. But when patients develop these reactions, we have to stop the immune therapy and give them high-dose corticosteroids. We often have to admit these patients for aggressive inpatient care as well. And then on the top right corner, that's showing this example of what we call bullous dermatosis. That's where you can get these like big blisters that look that can develop on the skin. This can vary, so you can have mild bullous dermatitis where we can treat that with topical steroids, but you can also have pretty extensive blisters that develop, and in those cases, patients will need high-dose oral steroids. And then this is just kind of showing the incidence that we see rash develop. So it's more common in the combination of ipilimumab and nivolumab as compared to PD-1 agents by themselves. And that's going to be the theme of the day. So combination is definitely worse in terms of the number of side effects we see. And then the steroids or the treatment is often supportive with over-the-counter antihistamines. You can use moisturizing lotions, and then we can use prednisone for those more severe cases, like I mentioned. So the next most common and the most severe side effect that we'll see is colitis, and that's basically describing an inflammatory reaction that can happen anywhere through the GI tract, so from the mouth to the rectum. And so the most common way people will present will be with inflammation in the colon, and that will present with abdominal pain and cramping and diarrhea. They can have nausea as well, and heartburn if they have more inflammation in the stomach or upper small intestine. But really, the majority of patients will present with diarrhea, so we think about that as most often the symptom to watch out for. Often patients will describe their symptoms are worse at night, which is a pretty common inflammatory symptom. And so we harp on this when we're starting patients on therapy to notify any changes in their bowel patterns. Initially, we can use just supportive care with over-the-counter antidiarrheals. We can sometimes modify their diet, but really once we start to see symptoms of colitis develop, it's pretty quick before we start steroids. This is what the colon can look like in a colonoscopy, so you can get these ulcers and just kind of diffuse erythema over the mucosa. It can be swollen, so lots of different ways it can present. Again, the incidence is higher when we are looking at the combination of ipilimumab and nivolumab. There has been a few retrospective studies that have shown that if patients use nonsteroidal anti-inflammatories, those are drugs like ibuprofen, aspirin, and Aleve, they will have a slightly higher risk of developing this enterocolitis from ipilimumab. And there was also a small case series of patients that they showed if patients were taking vitamin D prior to starting immune therapy, they had a lower risk of developing colitis. So I'll usually counsel patients to start taking vitamin D if I know I'm going to start them on immunotherapy. So typically the management is, as I mentioned, we'll do supportive care. They might need fluids if they're having really severe symptoms. We can modify their diet with what we call a FODMAP diet just to avoid foods that we know can trigger inflammation. But really we're starting steroids. And so we're typically using prednisone, although if patients are vomiting, we might need to give them IV steroids, but usually we can do this on an outpatient basis. And then this is kind of the first introduction where we're seeing these secondary agents. So infliximab and vedolizumab, these are other antibodies that we can use that are going to be suppressive to the immune system, more specifically to decrease that inflammation. So these are the two that we most often use for colitis. Infliximab is one that we use more often. This inhibits a cytokine that we call TNF-alpha. We will think about using this for patients who have severe grade 3 or 4 diarrhea, especially if they don't have any improvement in their symptoms after starting steroids for just 48 hours. If they're really not better within 2 days, then we'll start thinking about adding this infliximab. We would not want to use this in someone who had hepatitis as well, because this has been shown to lead to acute liver failure. So we have to make sure that we check liver function tests before we use that. The alternative would be to use vedolizumab. This is the antibody that's more specific for preventing T-cell activation and moving into the gut. So you have less of the systemic immune suppression with vedolizumab. There was a small study at MD Anderson where it looked like the response to vedolizumab was better than infliximab, so I tend to try to use this if possible. So another organ that we can see is liver inflammation. Typically what we'll see with this is an elevation in the transaminases. Rarely do we see elevation in bilirubin, but we look for that in all cases. Typically the median time to onset is about 50 days after starting treatment, so a month and a half or so. The severity can be variable. Usually patients don't really have significant symptoms. It's often something we just find on blood tests. And I just put here at the bottom, if someone has underlying liver metastases, when you might be able to continue their checkpoint inhibitor with close monitoring. And then endocrine toxicities, these are important because they're relatively common, but also these are the side effects that tend not to recover. So unfortunately, when these develop, they tend to be permanent. They're often found more on lab screening as opposed to symptoms. The most common hormone gland that we see get inflamed is the thyroid gland, about 14% for patients that are receiving immunotherapy, and then 6% will develop what we call hypophysitis. That's inflammation of the pituitary gland. And then very rarely we'll see diabetes develop, which is similar to an autoimmune type 1 diabetic where they lose the ability to produce insulin. And unfortunately, these patients will then become insulin dependent for the rest of their life. So for the thyroid gland, this is the most common one that we'll see with PD-1 monotherapy and also combination. You can see hyperthyroidism, which is increased thyroid hormone production. Typically this will develop early on, but will what we call burnout. So the thyroid gland basically stops making the hormone. So we usually just have to monitor patients and then look for the development of hypothyroidism later. The more common way people will present is with hypothyroidism, where they basically destroy the thyroid gland and they no longer make thyroid hormone, so then they're on thyroid hormone replacement indefinitely from there. Starting steroids for the development of hypothyroidism or thyroid disease does not prevent the permanent loss of function, so we don't use steroids to treat endocrine side effects, fortunately and unfortunately. The hypophysitis, so the pituitary gland is what we call the master hormone regulator, and so it basically controls the function of all the other hormone glands in the body. If this gets inflamed and stops making hormone, then you're going to see loss of hormone production in multiple glands. So the ones that we see most often is the thyroid and the adrenal gland, where we have to replace thyroid and cortisol hormones. Men are more likely to have issues with sex hormone dysfunction, so we also have to look at testosterone for male patients that develop hypophysitis. Women also can lose sex hormone production, but it doesn't seem to happen quite as often, but we still need to check that and replace that hormone if they develop this. Patients will often present with really severe headaches, and then we'll see these changes in their hormones. This is kind of dark, so I don't know if you can see, but the arrow is pointing to the pituitary gland where it's swollen here. So often we'll get labs to look at their hormone levels and then also MRIs to look at the gland itself. What's key in patients that develop hypophysitis is that they no longer can produce cortisol independently. They're really dependent on replacement. And the problem there is that when they're under stress, their body can't compensate. So they have to be able to increase their dose of steroids by themselves. So patients really need multiple counseling to be aware that they have to increase their dose of steroids if they have an acute illness, if they get the flu, for example, or if they have a procedure, or if they're in a car accident, for example. They also needed a medical alert bracelet. So healthcare providers, if these patients are found unconscious, that they know that they have adrenal insufficiency and that they can give them stress dosing. And then all patients should have a emergency injection kit where if they have lost consciousness, then someone else can give them stress dose steroids. Diabetes, we talked about this often, is very quick. So you can see a patient 1 week and their glucose can be normal, and then a week later they'll come in with a glucose of 800. Oftentimes they're asymptomatic, although sometimes patients will present in a severe complication of diabetes that we call diabetic ketoacidosis. These patients often don't have a rise in their hemoglobin A1C before their diagnosis, again, kind of suggesting this rapid onset. So we basically monitor this by just following glucose levels before they get treatment and or with their checkpoint inhibitors. And then once it develops, again, it's irreversible, not something that we can treat with steroids. It's really just treated by insulin, and then they're insulin dependent. For inflammation of the lungs, that can present in several different ways. Pneumonitis, pleuritis, and sarcoidosis are the most common ways. This is fortunately rare. It's more associated in patients who have lung cancer. And then the course of resolution tends to be a little bit slower, so often patients will need to have their steroids tapered over 45 to 60 days as compared to like 28 to 32 days for patients who have colitis. And then for patients that are not really responding to steroids, or if they have persistent symptoms beyond 3 days, then we'll consider using IVIG as a secondary agent. These are just some picture examples of what we might see on CT scan for patients that have pneumonitis. There's several different ways that patients can present with pneumonitis. Unfortunately, chest X-ray can miss about 25% of cases of pneumonitis, so CTs really are the preferred way to evaluate. And then once patients recover, there can be a lag time of about 6 weeks before you see resolution on imaging. So if they are symptomatically improved but still see evidence of pneumonitis on their scans, and you don't necessarily need to resume steroids at that point. But you probably will monitor more closely with more frequent imaging of the lungs. These are less common side effects that we'll see, so kidney inflammation, cardiac toxicities, hematologic toxicities, nervous system, and the eye, but I just kind of listed them here in terms of things that we might watch out for. Unfortunately, patients can die from these immune checkpoint inhibitor toxicities. The side effects that we see most often associated with death are the neurologic toxicities like encephalitis or myocarditis, which is inflammation of the heart. There have been patients that have died from colitis and hepatitis that have been refractory to steroids, but again, early intervention and treatment is key in preventing deaths from colitis and hepatitis. Myocarditis and encephalitis are fortunately rare, but their management needs to be very intense. Patients need to be admitted once they develop these side effects, so that way they can be managed appropriately. For the patients that develop encephalitis or myocarditis, we use really high doses of steroids. We'll use a gram of methylprednisolone, which is about 1,200 milligrams of prednisone. And if you think about a normal 1 milligram per kilogram dose of prednisone for the average person is about 70 milligrams. That's a pretty high dose, you can imagine. And we'll use that for a few days as that inflammation recovers. One thing that's important to know about cardiotoxicities is that they tend to co-occur with other side effects. So patients who develop inflammation of the muscle are much more likely to develop inflammation of the heart as well. So once that develops, you need to be thinking about myocarditis. And the same goes for a neurologic toxicity that we call myasthenia gravis. the last thing I just wanted to mention, so one thing we think about in adult care is the elderly and whether they can tolerate the treatments with any of our therapies, whether it's chemotherapy or checkpoint inhibitors. There have been a few case series where we've looked at the elderly population, and it doesn't seem that they're more or less likely to develop toxicities, but the tolerability is something to consider in terms of, are they going to be able to stay on steroids? Are they more likely to develop diabetes from steroids? Things like that. So they're a little bit unique in the way that we might approach the elderly and the checkpoint inhibitors in use there. And then lastly, I just wanted to briefly talk about cellular therapies. This is mostly used for hematologic cancers. We've used these therapies that are called CAR T cells. These are basically just modified T cells. You'll take T cells from patients and then genetically modify them so that they express a certain receptor that can recognize the cancer that you're treating. And this is really approved for lymphoma based on a CD19 receptor that's on the B cells of the lymphoma. So once those T cells are modified, we can infuse them back to patients, and then you should see that kind of T cell activation and killing. The unique thing about cellular therapy is they have their own kind of side effects that we typically see, and that's the cytokine release syndrome. And it's basically just a result of activation of multiple killer T cells and release of multiple different cytokines. But we know that IL-6 and IL-1 and IL-10 are predominantly playing here in the symptoms that we see. And this just basically causes a really severe flu-like reaction. Patients need to be in the ICU occasionally because of really low blood pressures. They need fluids and steroids to kind of support them. Initially, there was concern that steroids might decrease the efficacy of these treatments, but that's been shown not to be the case. So really early steroids are key. And then the secondary agent that we'll often use is this drug called tocilizumab, which blocks IL-6, which is one of those cytokines, which again will suppress that cytokine reaction more quickly. CAR T cells can also have this neurologic toxicity that's really associated with that cytokine release syndrome that presents with a few different neurologic symptoms like confusion, hallucinations, and seizures. That is also managed with steroids, but instead of tocilizumab, we'll use a drug called siltuximab, which binds or blocks IL-6 in a different way. And then lastly, one thing that we've looked at is for patients who develop these side effects is cannot predict whether they might have a better response in terms of their tumor control. And I would say the data is mixed, but it does seem like there's a small association that patients who develop really severe toxicities might have better outcomes. So this was a study that was done at MD Anderson where they had 290 patients of different tumor types treated with an anti-PD-1 agent, and they showed that the patients that developed severe grade 3, 4 toxicities had an improved overall response rate, and a progression-free survival. This was a similar study that was done in Europe, again looking at a combination of different tumor types for patients treated with anti-PD-1, and again showed that there was an improvement in the progression-free survival and overall survival for patients that developed severe immune-related events. And then this was a study looking at patients specifically with lung cancer who were treated with anti-PD-1 agents, and again seemed to show an association of improved response rate, overall survival, and progression-free survival if they developed particular side effects. What we don't know is the impact of what steroids and these immune-suppressing treatments might do for long-term tumor control. There's conflicting data about whether steroids might suppress the kind of anti-tumor response. Although I think some of it might be kind of the ways in which steroids are used, but so that's one thing that we sort of think about before using steroids is whether it might negatively impact their tumor control. For patients, they can have different types of side effects develop. The symptoms can come and go. They can have multiple side effects develop during their course of treatment. And then another big question is whether you can, after they've finished their steroid taper for treating their side effects, can you re-challenge them with the checkpoint inhibitors? And so that's a lot of questions that we still don't have the answer to. All right, sorry, I tried to breeze through that last a little quicker, but any questions?
Please feel free to put any questions in the chat, or you can get off mute and ask your question.
Thanks, Dr. Medina. I had just one quick question. Towards the end, you mentioned that there's no real strong correlation, at least between side effects and outcomes. Are there any good signs, though, clinically, apart from, when you look at the scan results to predict any sort of outcome, or is that also not really established?
It is a challenge. We know that the scans can be misleading in terms of predicting response because it's not always representative of what's happening within the tumor itself. But there are certain side effects that tend to predict better outcomes for certain cancers. So melanoma is an example. When patients develop vitiligo, that has been associated with improved outcomes. So even if they don't seem like they're responding yet, if it's too soon or if their scans are stable and they develop vitiligo, then it is somewhat of a reassuring sign that eventually they'll start to have imaging that correlates with that response. So, not always, but it's a pretty high association.
Awesome. Thank you.
Yeah.
Well, if there are no other questions, thank you again, Dr. Medina, for this presentation, and thank you to everyone for joining.
Thank you so much for the invitation.
Have a great day, everyone.
Thank you, Dr. Medina.
Thank you. Bye.
Bye.